Thank you, Ms. Orlowski. Ms. Rice, you're recognized for 5 minutes.
Thank you, Mr. Chairman. I feel like I missed something here. I'm just trying to figure out why, and maybe Mr. Murray, you can answer this question. Why is there such a reluctance to apply FAR regulations when you're talking about non-VA care? If you can give that answer succinctly, because I have a lot of other questions.
I don't sense there's a reluctance at the leadership levels. In fact, all the leadership levels I see, PC3, choice, provider agreements seem to be the preferred approach for providing care in the community. That specific, and if you want to delve into this, I think that Chief Acquisition Officer, the head of contracting activity for the Health Administration might have some sense for why this is true or could be true in the field.
So, ma'am, one of the things that we tried to address, and we tried to do it with the legislation request that came in, was to recognize that there are some vendors that may shy away from doing business with the government. We're not known as being the most streamlined and the most easiest to deal with. Vendors have to get done in Bradstreet numbers. They have to apply for federal contract wage statutes. There's a lot of additional activity they do to do business with the government. And what we're trying to recognize with the legislation is there's an order of precedence. We want to start and deliver and provide care in our VA medical centers. Next is with contracts. Next with agreements. Our last preference would be what has been termed the individual authorizations. So we want to have that as really kind of the backstop, that as we go through this priority, this hierarchy of providing care, we see that as really our least preferred option, but one that we don't want to take away from approximately 400,000 veterans that are being served by some of those small providers that may choose.
It's become a $7 billion backstop. Right?
I don't know all 7 of that. All 7, I believe, is for overall fee, and some of that has happened through FAR and non-FAR.
Well,
I don't have the breakout.
The problem is that there's no comprehensive auditing that has been done. And I guess, Mr. Williamson, if you could, what I see a pattern of is either GAO or Inspector General saying, here's a problem, here's how you fix it, and a intentional or negligent failure on the part of the VA to take recommendations and actually implement them. So can you just tell us what you've recommended the VA do and where they are still lacking?
Well, of course, as you know, we put VA on our high-risk list very recently, and part of the justification for that was that they are not implementing many of the recommendations. In fact, there are over 100 recommendations we've made that VA has not implemented, just in the healthcare area alone. There are 22 recommendations, and I don't want to use all your time up, but let me give you a couple examples. One is we recommended that VA keep track wait times for veterans that went to non-VA providers. They have not yet done that. We've talked to them about it. They still haven't done that.
What's the reason for them not having done it?
We don't really know.
Well, when you ask them, you tell them how to do it.
I think what they're looking at, they want to close a case from the time the veteran starts the process of getting an appointment till the time the claim's paid. They want to do that in 90 days, and they are tracking that, but for some reason they're reluctant to track the 30 days.
Why?
Good question. I don't know that they've given us a great answer on that.
What would be a good answer? Is there a good answer?
They probably don't have the systems to do it. It takes a lot of work. It does. It does take some good data, but that's not a good reason necessarily for not doing it.
Mr. Williamson, so you've laid out a blueprint for how the VA can improve, whether it's tracking wait times, doing better audits to see where these multi-billion-dollar expenditures are going. And I guess maybe there isn't an answer to this, that it seems to me that you have not been able to get any satisfactory answers as to why your recommendations have not been implemented. And maybe you're not the right person to answer this, but I don't know if anyone at the VA, I haven't heard Mr. Murray give any explanation as to why. So,
well, I think part of it is that it always comes back to the same issues, no matter what what program you're reviewing in VA. The data is often insufficient. The automated systems they have, in many cases, cannot produce the kinds of things they need. And it comes down to a lack of oversight, both at the local level and at the headquarters level. And time again, the claims processing problems we found on the emergency care for non-service connected veterans, same thing.
the problem is that there will be no overall cultural shift at the VA unless there is meaningful oversight, whether you're talking about this issue or you're talking about how whistleblowers are treated or anything else. And that's really at the heart of the problem, isn't it?
Comes down to accountability, and it's not there.
Thank you, Ms. Williamson. I yield back, Mr. Chair.